Is the administrator of substance use disorder services at Hagera Health and leads the oversight and development of substance use disorder services for the organization. He received his Master's of Social Work from Eastern Michigan University in 2002 and is a certified advanced alcohol and drug counselor and certified clinical supervisor through the Michigan Certification Board of Addiction Professionals. Scott began his career in 1994 as a therapist working in residential and outpatient programs with adolescents and adults struggling with addiction. He was eventually promoted to multiple management positions and has served as a clinical supervisor and administrator for the last 13 years. Scott has been a speaker at many professional, collegiate, and community events and enjoys sharing his experiences, knowledge, and passion for serving the substance use disorder population with others. And we are also very fortunate to have Scott on our board for our Northwest Wayne chapter. So thank you, Scott. Melissa is the clinical director for Hagera Health and providing clinical and operational oversight for most programs and services. She has a master's degree in counseling and is a licensed professional counselor in the state of Michigan, as well as a national certified counselor. In 2016, Melissa obtained her certificate in integrated behavioral health and primary care from the University of Michigan. She is a master QPR trainer, question, persuade, and refer, and is also trained in critical incident stress management. Having lost 2 family members to suicide, Melissa has been passionate about suicide prevention throughout her career. As the lead implementer for the Zero Suicide model at Hagera Health, she developed a work plan for training staff on evidence-based practices for suicide prevention and post-intervention development of policy and procedures, data collection requirements, and quality improvement processes. She has expanded training into the community and has trained over 800 individuals to become suicide prevention gatekeepers. That's excellent, Melissa. Chris is the Engage Program Coordinator and Peer Program Supervisor at Oakdale Recovery Center at Hagera. Engage is a mobile substance use disorder crisis intervention team in Wayne County. Chris has been in long-term recovery from substance use disorder since October 6th of 2008. We're excited about that. And has been working in the addiction treatment field since 2010 in a variety of capacities, including outreach case manager, recovery advocate, public speaker, musician, performer, event organizer, peer recovery coach, and recovery coach trainer. Chris is also a founding member of 2 recovery community organizations, the Washtenaw Recovery Advocacy Project and Michigan Recovery Voices. He is a fierce advocate for and believer in multiple pathways to recovery. So please welcome our speakers this evening. Scott, it's all yours.
Thank you, Dara. I'm going to share my screen as well. So you should be able to see mine now. All right, excellent. So appreciate the introduction. We're happy to be here. We are all from Hagera Health. We're a large behavioral health organization in Western Wayne County, and Melissa's going to talk a little bit more about Hagera when it's her turn. What I'm going to focus on is just the impact of COVID-19 on substance use disorders and the use of drugs and alcohol, as well as the substance use impact on COVID-19. So I wanted to start out just talking a little bit about why do people use drugs? Well, and these are very general reasons. They're more individualized. When you talk to people, individuals, it's more specific to them. But these are just general reasons why people use drugs and alcohol. And so some of them are depression, to cope, to escape feelings, to escape memories, to escape unhealthy situations or what have you, boredom, stress, grief, illness. So there's a lot of different reasons why people use drugs and alcohol, and COVID has certainly had an impact on all of that. So one of the things that when you start, I wanted to find some research and look at really what impact has COVID had on everybody and their emotional and their mental health. So this is one study, and it was done in October of 2020, and it involved college students. And they asked these students a bunch of questions, and one of them was, how would you say your emotional health has been impacted compared to before the COVID-19 outbreak? And as you can see, is 62% of those folks said that it's either somewhat worse than before or far worse than before. So you can see that obviously the toll that it's taken on all of us has it's been a major impact on all of us in our emotional health and our mental health through isolation and separation from everybody. We were talking earlier about giving ourselves hugs versus giving other people hugs. It's been a tough time the last year and a half for everybody. This is the same study and just a different question. Which of the following mental or emotional challenges have you experienced in the past month? And you can see a majority of the people said things like anxiety, social isolation or loneliness, depression, difficulty coping with stress. And even though they're smaller percentages, there's still a lot of concerning things on here. Suicidal thoughts, and Melissa's going to talk a little bit more about that. Substance use issues, a lot of impact that COVID-19 has had on all of us. Another study looked at anxiety disorder and depressive disorder in adults. And this study looked at folks in January through June of 2019, and 11% said that they had anxiety or depressive disorders. January 21, now it's up to 41%. So a 30% increase in those people feeling that they have again, they're struggling with anxiety, they're struggling with depression. And again, there's a lot of reasons for that with COVID. People struggle with it beforehand, but COVID has just really intensified all those feelings and the fear of getting sick, to being separated from everybody, from loved ones, whether it be young people or old people, older people who have been in nursing homes or what have you, there's been such an impact on the separation, not being able to be together and be social and go to social events, whether it be go out to dinner or go to a support group face to face or anything like that. And so all these have really intensified these emotional and mental health issues. And so when you go back to why do people take drugs, when you start looking at these again, depression was there before, but now it's more intensified. Now more people are experiencing depression. Looking at to escape, boredom, social isolation or loneliness was one of the higher percentages on that question. So again, that boredom goes from boredom to being lonely to be isolated from others. Stress of the whole, everything might be a job loss, might be just other things that we've lost with COVID. And it's not just the people who get sick, it's the loved ones of those people as well, and the loss that they've experienced and the stress that they've experienced. So obviously, if all these are reasons why people use drugs and alcohol, and then through this process, through that process, these feelings and these issues have intensified and become more common, then you're going to see an increase in substances. If we use because of depression, loneliness, boredom, to escape, and then those are more intense now, the substance use is going to become more intense. And so this was a study where these folks looked at results of urine drug analysis and found just positivity rate for cocaine, fentanyl, heroin, and methamphetamine. And what they found was that you can see as of March 13th, 2020, when the national emergency, the declaration of the national emergency for COVID, you can see a spike in substance use right away, which again makes sense. If that anxiety is increasing, that depression's increasing, that loneliness is increasing, these are the ways that that some people deal with those emotions and those situations. And so as those intensify, the substance use intensifies. And so we've seen a big leap in that. And while certainly, and especially in March, April, and May, when the stay-at-home orders were there, and we weren't going out or doing anything. You were basically stuck in your home for most of the time. And some people literally stuck in their home. They literally couldn't leave because of fear of getting sick, or because they were sick, or what have you, because they have all the risk factors that put them at a higher risk of getting COVID. And even though the numbers look in these graphs, some of them start going down, it's still higher than what it was before. And so not only does COVID have an impact on substance use, but substance use has had an impact on COVID. And so this is a study that was done where they looked at comparing people with a lifetime use of substances and recent use of substances. And the impact that had on contracting COVID-19. And what they found were is that people with a substance use disorder at any time in their lives were 1.5 times more likely to contract COVID-19 than those without a substance use disorder. So the substance, if their use of substances made them more susceptible to acquiring COVID-19. Those with a recent substance use disorder are more than 8 times more likely. So if it, which makes sense. More recent means you're going to have more physical impact, physical effects from the substances. And so, again, you're going to be more susceptible to obtaining COVID at that point. People with an opioid use disorder are a particular high risk for COVID, and we're going to talk about that in a minute. And then COVID-19 patients, with substance use disorders are more likely to require hospitalization and to die from COVID-19 than those without an SUD. So why is that? So they started looking at that. And so this is the same study. And the first set of bars you see are all COVID-19 patients. So they just looked at patients with COVID-19. Those patients that had a lifetime substance use disorder, those patients that had a recent substance use disorder. So lifetime being they had an addiction or used substances a while ago. Recent is obviously more recent. What they found that more than 40% of the COVID-19 patients with a lifetime or recent SUD diagnosis required hospitalization compared to 30% among all COVID-19 patients. So they're more likely, if they have a substance use diagnosis, they're 10% more likely, or 10% more of them required hospitalization. 10% of COVID-19 patients with an SUD diagnosis died compared to 7% of all study patients. And while we say, well, maybe 3% isn't that much, when you think about how many people have contracted COVID-19, that's a high number. Even that 3% is a high number of people. What was also interesting is hospital and death rates did not differ between lifetime SUD diagnosis and recent substance use disorder diagnosis, meaning that use of substances has a major impact and made them more susceptible to COVID-19. So, it didn't really matter if it was recent or 10 years ago or 20 years ago, they were more susceptible to it. So why is that? Why are people who have a substance use disorder more susceptible to COVID-19? Well, there's obviously a physical impact. When you use drugs and alcohol, there's going to be a physical impact in that. And a lot of that has to do with the heart and the lung. Opiates, as I said earlier, people are with an opioid use disorder are more susceptible because, use of opiates works on that respiratory system and slows that respirations down. And that's what leads to overdoses and that kind of thing. So it impairs that lung function, impairs heart function. Other drugs and alcohol impair heart function as well. And so those are the people, the heart and the lung, if they're not operating correctly, that's when people had difficulty with COVID-19. They were being put on ventilators and that kind of thing. Also, drug and alcohol use promotes the development of things like diabetes and hypertension. Those were risk factors. Those people who had, they knew early on that those, folks with those kind of, health issues were at a higher risk to get COVID than other people. And use of substances promotes that development of those disorders. So the substances really have an impact on your physical health, which really has an impact on your ability to not, to get COVID, but also have the serious side effects of COVID. There's also barriers to healthcare that people who struggle with addiction or use drugs and alcohol have, and we're going to talk about that in a minute. And there's also just with the COVID-19 precautions, social distancing, being in environments with a lot of different people. It's just, that this population, these folks, have just more difficulty with those kind of things. And we all have difficulty with social distancing by all means, at our Oakdale Recovery Center, our residential environment. We're continuously having to tell folks to spread apart, wear your masks and those kind of thing. And part of it makes sense. They'd much rather, they'd much rather sit at a table with 4 people playing cards and 2 people, not doing much interacting. So, and especially in that early recovery time, you're just looking for connection. You're looking for someone to share with or get support with. And social distancing and everything else has really, impacted that, especially in the beginning of COVID and everything else. So I talked about barriers to healthcare. So some of those barriers, in regards to substance use disorders, part of it is stigma. There's obviously, and we've talked about it in these meetings before, there's obviously a stigma to those folks who struggle with addiction. They're reluctant to seek medical care. They don't, there's a trust factor there. There's a fear factor where if my doctor finds out that I'm using drugs and alcohol, are they gonna stop treating me? Are they gonna take away the medication that I'm getting for this other disease? Are they gonna take away that because they don't trust, they don't like, the interaction of those drugs and alcohol with that medication. There's a lot of shame that these folks feel as well. And having to admit that, yes, I am addicted to drugs and alcohol. So that stigma really stops them from reaching out to other people. And then the medical community, there's still a stigma out there as well. And we've done a wonderful job the last 5-10 years, especially at really educating the medical community on that addiction is a disease, that these folks are sick, that it's no different than other diseases that they treat. But hasn't gotten to everybody. And so these folks, are looked at as, they're lazy, they don't care, they're selfish, they don't understand that lack of control that goes along with addiction, along with use of substances, or anything like that. So, there's a stigma that stops them from reaching out to healthcare, reaching out, for resources. Vaccinations, vaccinations are everywhere now. Well, anybody can get. I just read today that now it's 12 years and up. It used to be 16 years and up. Now it's down to 12 years and up. And we have so many sites and so many, ways to get that. But those resources, resources are not always there for folks who are struggling with addiction. They're not, and it's just, they might not have the knowledge. I get a lot of information just from Higuera, and working at Higuera, I get access to a lot of information. I was able to get vaccinated back in January and February because I was an employee of Higuera. Those are advantages that I have. Folks that, might be unemployed, might be, again, don't have a lot of resources, lack transportation, the ability to drive, what have you, they're not going to have that knowledge, not going to have those resources. And then also, most of these have two injections to be vaccinated. So, we, for example, at Oakdale, we're able to take people to get vaccinated, and we're actually going to have a lab coming in soon that'll come in on a weekly basis and vaccinate people, which is wonderful. But they're not with us for 2 months or whatever. If they've been with us for a couple of weeks, they decide, okay, I'll get vaccinated. Then they leave 2 weeks later. Somehow they got to get to that second appointment 2 weeks after that. And while we'll try to set them up with aftercare options or what have you, it's more difficult for them to be able to get back to that site to get that second vaccination. So again, there's just more barriers. And then there's less treatment opportunities. Unfortunately, that's, COVID has had a major impact on the behavioral health, treatment setting. There's decrease in withdrawal management and residential beds. We have 45 beds at Oakdale. Because of COVID, we decreased that down to 35 to promote social distancing. We're not the only one. Every residential provider had to do that, not only in Wayne County, but throughout the state. So there's just less beds for these people. You've got more people using substances, using more intensely or what have you. And you have less beds for those people to use. So there's longer waiting lists, longer waiting times. Virtual versus face-to-face services. Everything before COVID was face-to-face. We didn't do much virtual, many things virtually at all. Virtual really had to do with folks in the more rural communities. But when COVID happened, we all had to do a 180, and we all had to get virtual services going. And there's been a benefit to that, but it's also been a barrier. It's been a wonderful opportunity for people it's opened more doors for people, that you just have to have a smartphone, or you have to have, a computer. And when we first started with virtual at Higuera, for example, we just did phone services. We called you on the phone. If you couldn't get online, okay, we'll call you on the phone. We'll do a session over the phone. So it's given a lot more opportunities for people, but, just like this meeting, this is a wonderful, venue for us to do this, so to speak. We have the opportunity to do these meetings via Zoom, but as we said earlier, it'd be much nicer, and we would certainly enjoy it more to be together and to be face to face and be in a room together, and there's more connection that way. And same thing with treatment services or what have you. If you're working with a therapist, you're getting benefit out of that virtual treatment, but you're also, it's not, you might not get as much out of that session without being face to face with that person. So sober housing has decreased. There's some shutdowns. A lot of programs have shut down. There's a loss of revenue because of COVID. So there's less opportunities that way. And then also in residential environments or housing environments or anything, when you have one patient test positive for COVID, then everything has to shut down. You're missing shutdown. And so again, less opportunity for people to get services. We have less beds. Now all of a sudden, let's say Oakdale, for example, is shut down to admissions for a couple of weeks while we work through this whole COVID process. That's 35 less beds that are available to people in Wayne County. So it's just, there's been a lot of barriers that have been, as a result of COVID. However, we always like to look at the positive too. We don't always want to look at the negative, and not everything is horrible. So, excuse me. So there have been some positive changes to the substance use disorder, treatment community and recovery community as a result of COVID-19. So again, we talked about virtual formats, and it has eliminated some barriers to accessing treatment and services. Well, there, AA meetings and smart recovery and all those, they have a lot more virtual formats now for people. So there's a lot more. Everybody's becoming more comfortable with that aspect as well. So that's been an advantage in a lot of ways. Medication-assisted treatment, methadone and buprenorphine and naltrexone, medications to help people with their substance use disorder. There have been a lot of changes in that field as well. They can have telemedicine versus face-to-face. You used to have initially you had to have a face-to-face appointment. Now they loosened that up a little bit, so you could do some virtually. There's longer take-home times for methadone. When you first start with methadone treatment, you have to go into that methadone clinic every morning. Then eventually you'd be able to do take-homes maybe a week at a time. They extended those to where it could be up to possibly a month, depending on each individual situation. So there's been some expansion of the rules and regulations regarding medication-assisted treatment to help people access those services. There's been an increase in mobile programs with the philosophy, you can't come to us, so we're going to come to you. We at Hagera have increased our mobile programs, but there's been other ones that'll go into the community and to the person and continue to eliminate any kind of barriers. You can't get to us, we'll come to you and we'll provide those services. You're in a setting we can't get into because we can't go into the building, but maybe we'll be outside and people can come outside and get those individual services. So there's been an increase in mobile programs. There's also been an increase in funding, and don't get me wrong, we have not financially, we have not done well in the treatment community because of COVID, and certainly have lost a lot of revenue. But there has been focus, obviously, in the state level, the county level, of increasing funding to assist getting through this process, and whether that be accessing and obtaining PPE and other assistance. There has been some increased funding and different programs created because of COVID. So, there's been some positive aspects to it, but we in the treatment community understand that this is a long road that we still have to go. And even once we get to normal, whatever normal looks like, and get through this pandemic, there's still going to be long-lasting after effects for people. Those emotional and mental and behavioral consequences and impacts that they've had because of COVID, those are going to continue on, and those are the things that we'll be dealing with for a long time. And we're certainly ready and prepared to deal with that, and we'll continue to do so. But I appreciate everybody's time and attention, and now I will turn it over to Melissa.
Hey, Scott, before you turn it over to Melissa, there was just a quick question that I think needed some clarification.
Sure.
The question that came through the chat was, do you have mobile methadone units, or were you saying that people get longer take homes for methadone and that the mobile unit program was expanding? That's what you meant, right?
Right, correct.
That's what, yeah, somebody had thought that I think it was Kelly, thought maybe you had mobile methadone.
Yeah, that was
me.
So I was about to say that's kind of interesting, but
right.
Okay.
No, I don't know of any mobile methadone
clarification.
programs. No,
Yeah.
mobile programs, where they're going out and doing harm reduction techniques, or making Narcan available, or a variety of different things going in. We have programs where we go into the hospitals and like I said, go where the people are versus waiting for them to come back to us.
So similar to like the units at the health fairs when they have the mobile units there taking blood pressures and stuff like that.
Yep, they're not our programs, but there are other programs like that, correct?
Okay, thank you.
Sure.
Thanks for clarifying.
Okay, I guess I'm on, huh? I do not like following Scott when he presents, so he knows that. And actually, I don't like following Chris either, who presents after me. So, but that's okay. Thank you so much for having us today. Really appreciate it. As Scott said, we are a behavioral health organization, Hagera Health. But what I wanted to point out about Hagera is we recently became a certified community behavioral health clinic, also known as a CCBHC. So that's going to be an acronym or term that you're going to hear as we proceed into the future, as Michigan has a lot of now CCBHC providers. in the state, which is great. What a CCBHC does is it opens access for individuals who may be underinsured or uninsured. And that's excellent. We have a lot of individuals that come through our doors, for example, that can't get specialty services because of their insurance. They might have Blue Cross Blue Shield, for example, but can't receive a sort of community treatment, or their children can't be in a wraparound or home-based program. So this funding that we just received in 2020 really allows us the opportunity to get out into the community more and provide more services for people. So Higuera offers 30 programs and services to the community, substance use disorder and mental health, as well as youth prevention, primary care, and then we also operate community outreach for psychiatric emergencies, also known as COPE. So we hold the contract to provide adult crisis services in Wayne County. We also offer crisis residential programs too. So we have 6 locations, those 30 programs and services, and one of our more recent programs that we just developed and received grant funding for is called Pathways for Suicide Prevention. And that's our latest, newest program, really designed to meet people in the community, in the hospital, provide rapid treatment to individuals who are experiencing a suicidal crisis, had one, made an attempt. So we are providing the follow-up service right out of the hospital, which is the highest risk for suicide, 300 times greater risk actually for suicide is right out of an inpatient hospitalization. So we have been providing that service for 6 months, treated 63 people, which doesn't seem like a lot, but in times of COVID and not being able to get the referrals that we really needed, we're doing everything in our power to get out there and get those referrals in the door. So I'm gonna go ahead and share my screen. I don't know if I'll, doesn't matter, right, how many times I've done this. Sometimes I don't do it right. So let's see here. No, that's not right. Sorry, hold on just a minute. Let me do it this way. Shoot. What do they say? Zoom happens, right? There we go. All right. No, I don't want to record. Ah, sorry. This is not good. Let me stop. Hold on, one more time. 3rd time's the charm, right?
It happens. It's okay.
I
Take your
know,
time. I get flustered when I'm trying to do that as well. So
We're
All right.
with you. We got you.
Can you see my screen?
no.
Scott,
Did you hit share?
I
at
thought
the
I
bottom?
did. Let me try this. I'll get there. Now, can you see it?
Yes.
All right.
Good job.
Thank you. Takes me a minute. I present usually weekly, so I'm actually surprised I struggled so much, but that's okay. So I just want to go over just some facts and figures for you all. What we've heard over the course of the last year is that suicides were on the increase, that they were on the rise. And so just to put everything in perspective, suicide is the 10th leading cause of death, and homicide ranks 16th, but we do hear about homicide more frequently than we hear about suicide deaths, and it is the 2nd leading cause of death for youth. But there has been a decrease in suicides. So while we've heard, and we heard very early on, right away in March, that suicides were going to increase as a result of COVID-19, they really haven't. In fact, they've decreased in 2020. Suicide claimed 47,000 lives about in 2019, and then that dropped to just over 44,000 in 2020. So that is, we're cautiously optimistic in the suicide prevention, postvention world. That really speaks volumes to the amount of work that is going on now with suicide prevention and postvention. And when we talk about suicide, we oftentimes talk about prevention a lot, but we don't really talk much about postvention. So I will share some information about that. And just to put things into perspective too, sometimes we hear this stuff, that doesn't mean there aren't crises going on. So while there has been a decrease in suicides, there has been an increase in the reach out for crisis services. So we have seen an increase in that in 2020. So approximately every 11.1 minutes, someone dies by suicide. That's 1.1 approximately attempts annually, although I will say that there are probably a lot more attempts than that. Those are really underreported. Oftentimes there may be an attempt where somebody wakes up in their home, never goes to the hospital, never reaches out to behavioral health treatment or medical treatment, or they're aborted attempts. Somebody may stop them, but as Scott mentioned earlier, due to stigma and other reasons, people don't seek treatment. But there has been a 5.6 decrease in the last 3 years, and that's really great news to hear. So I am, as mentioned earlier, I am a survivor of suicide loss. I've lost 2 family members to suicide. I lost my grandfather and my uncle. My grandfather died just a couple of months before I was born, and my uncle, who was 16 at the time, was witness to that death. And that really followed him throughout his years. And it really changed the trajectory of our family as well. So for every one loss, you know, we think about that, there are about 115 people, probably more like closer to 130 people impacted by that loss. And at least 6 of those individuals that are impacted by that loss really have devastating effects. And that was the case with my uncle. And back then, and I don't want to date myself, but I guess I will, in 1973, there wasn't suicide prevention programming. There certainly wasn't zero suicide. And there wasn't really a lot of trauma-informed treatment programming going on. And my uncle turned to drugs and alcohol. So that was how he was able to proceed with his own life during that time. It wasn't until I was 16 years old that I realized or was told or informed that my grandfather had died by way of suicide. And that was after my uncle made his first attempt. So at that point, he was using alcohol regularly, not sure about his drug use, but it was devastating. He did end up going into treatment about 3 years after that first attempt, and he was sober for 19 years. That's when he relapsed, he slipped, and did not think that he could come out of it. And he and I had multiple conversations. This was in 2008, trying to get him into treatment and then getting him the help that he needed. He was hospitalized. And I think one of the things that we tend to do is when someone's hospitalized for suicidality or a mental health condition, we kind of think, oh, well, they'll be better after that inpatient stay. And that's what I think back then we all thought. So when he came out of the hospital, we felt like he was in a good place. That was a good place to be. And that's when he died. So that's why I talk about postvention services being so impactful and so important, and making sure that when we are talking about suicide with an individual or their suicidality, that we're making sure that we're finding them treatment for that as well. And that's something that I think in the substance use disorder world, we haven't really done a great job of across the board. In fact, we are a zero suicide organization. So what our focus has been on over the last 3 years is training and development of suicide pre- and postvention services for our staff. We've trained all of our staff in evidence-based practices to support that, as well as develop policy and procedure. But one of the areas of focus is substance use disorder and the impact that has with suicidality. I just reached out to a zero suicide consultant that we use, and she said the same thing. This is across the nation. People have not been really focusing on suicide and substance use disorder, and that really does need to change. So as we talk about suicide and suicide deaths, these are the methods of 2018. These really haven't changed much. Firearms continues to be the most frequent use, as followed by suffocation and then poisoning.